Thank you so much for joining today. We're really excited that you're here for our Oncofertility Consortium webinar. The webinar will take about 45 minutes and be followed by 15 minutes of questions and answers. Please keep your mic muted and your camera turned off during the webinar to avoid background noise and ensure a smooth broadcast. If you do have a question, please post it in the chat. We'll have an open discussion at the end of the webinar, and you'll be able to turn on your mic and camera at that point to ask questions. The webinar will also be recorded and uploaded to our Oncofertility Consortium YouTube channel. We're really excited today to welcome Dr. Irene Sue. Dr. Sue is the professor of obstetrics and gynecology and reproductive sciences in the Division of Reproductive Endocrinology and Infertility, and she is the program director for the REI Fellowship and the director of the Oncofertility program at the University of California, San Diego. And we're so excited today that Dr. Sue is going to talk to us about telehealth oncofertility care.
Good morning, everyone, and afternoon, depending on where you are. Thank you for this opportunity to talk about work that we have ongoing and hopefully have some discussion with feedback from the community. So this is an overview of our trial on telehealth oncofertility care. We like to call it Let's Talk Fertility. This is a trial in collaboration among UC San Diego Health, Rady Children's Hospital here in San Diego, City of Hope, and Cancer Resource Center of the Desert, which I'll tell you about in a few minutes. So the background, of course, is that reproductive health is important to young cancer survivors. And this is in the context of having effective fertility preservation methods. And so we all know that there are guidelines that really speak to how healthcare providers should address the possibility of infertility with patients treated during their reproductive years, both at cancer diagnosis and in survivorship. And so one of the buy-ins for this trial among the sites is really the goal of providing quality and value care. This is how this started here at Moores Cancer Center. Yeah, so until 2016, I would say that my work has largely been in epidemiology. And because of the Cancer Center goal of improving the proportion of patients who got appropriate oncofertility care, I started on my first QI project. And with the help of folks in the Cancer Center, we realized how low documentation of oncofertility discussions is. And this is showing that the proportion of patients with documented fertility risk discussion was quite low, with the yellow being that of academic centers and then blue being that of UC San Diego. And so iteration number one, and I see one of my colleagues, Dr. Senya Shiliak-Saba, on the call with us. She was with me at the time as our postdoc. And it was so easy to say, well, if it's not being documented, then why don't we put a referral order in and generate a smart phrase to document the discussion? Why don't we email oncology providers? Because really all they needed was a tool for us to help them document this risk discussion and to nudge. And in that way, we would increase fertility risk discussion. Yeah, a little bit. And then it fell. And so I think that where we left was the knowledge gap is how can we use telehealth technology or EHR-based technology to improve oncofertility care delivery. And then a second question really was, can this care and can these interventions be scaled? How do we adapt and scale care delivery across adult and pediatric settings, academic and community settings? And over this time, there was an interesting NOC for telehealth and oncofertility in cancer care, And so this is a NOC from the NCI where they expressed interest in projects focused on patient-provider interactions, effectiveness to support cancer survivors, including treatment of comorbidities, really measuring the impact on patients, families, caregiver experiences, evaluate the quality and effectiveness of telehealth interactions in promoting patient-centered communication, intervening at multiple levels, and populations that experience inequities in care. So this is our overall paradigm that we want to evaluate a technology-assisted intervention for tailoring oncofertility care in adolescents and young adult cancer survivors. And this is a step-wedge cluster randomized control trial, and I'll show you what we mean by that. And the idea, of course, is that there are newly diagnosed young cancer patients who undergo an oncofertility care intervention. And that with that intervention, we hope that patients will undergo goal concordant oncofertility care that meets their needs. But for the organizations, that this is consistent, quality, and efficient delivery of this care. And if we can do this for individual patients and do this for organizations more systematically, then we hope that we will have the ability to preserve fertility and lead to healthy future families and improve the quality of life of this population. Some of the work that we did was to understand what the core components of oncofertility care delivery are. And so across the top, you'll see that it starts with an oncofertility needs screen. Then there's a gap between oncology referrals to fertility consistently. Then an oncofertility consult has to take place and fertility preservation services ensue if appropriate. And so multi-level barriers that I'm sure we all experience in our day-to-day clinical practice show us that the need screen, a barrier is the patient-provider communication along the way. The referral between oncology and fertility also meets barriers of clinic-to-clinic coordination. Consults require specialist access, which means that patients, referring providers, and clinics need to be available. And a significant component of this care is financial hardship. So to this end, we developed 3 intervention components. One is an EHR-based oncofertility needs screen and referral pathway we'll call a nudge. The second is the ability to do this counseling via telehealth. And the third is financial navigation via telehealth. And so these 3 interventions are really operating in a hub and spokes model for oncofertility care. So the idea is that not every oncology center has access to fertility specialists on site and vice versa. And so what happens is that you have adult oncology clinics, pediatric oncology clinics that feed into the oncofertility hub. In this virtual hub, there are fertility specialists and oncology social work navigators for financial navigation. And then the other spoke are fertility preservation clinics. So in this model, we have UC San Diego and City of Hope and Rady Children's as the spokes for the oncology clinics, UCSD and CRCD, which is the Cancer Resource Center of the Desert. CRCD is a nonprofit cancer navigation group located in Imperial Valley, which is at the border of the US-Mexico border, a little east of San Diego County. And so they have a long-standing commitment to the community of cancer navigation, which has required navigating health insurance. And so we've partnered with them in multiple CBPR projects, and excitingly in this one for helping us to understand the type of financial navigation that our patients need. And then following oncofertility hub activities, then patients are referred out to fertility preservation clinics, which can be either here at UC San Diego or local to them. So component 1 of our intervention was an oncofertility needs screen nudge. And so what you'll see here is iteration 1, where we are prompting oncology providers that reproductive health counseling for newly diagnosed and post-treatment cancer survivors is recommended and is a quality metric. Please order the fertility preservation program referral for counseling. And so a couple of things to note here is that the default is ordering. And then if you do not order, then we're asking for acknowledgement reasons. So for example, the patient declines to address today. There's no fertility needs now. For prognosis, there's not enough time before cancer treatment, not discussed at this visit, currently on treatment, and other. The reason why these acknowledgement reasons are important is as a part of clinical decision support, it's also adaptive. And so the idea is that this nudge has set age criteria, diagnosis, and visit type. And it's smart in terms of if you say that there's no poor prognosis for a patient by one of the oncology providers, then this nudge will not appear for any of the other oncology providers who's taking care of that patient for 12 months from the time that this nudge has been sort of addressed in the first place. And that's, of course, because one patient could be taken care of by multiple oncology providers and it just takes the first provider who addresses this issue to complete it for the whole team. So this is what I mean by look back to reduce alert fatigue. this best practice advisory or a nudge is related to a referral order. And so rather than providers having to find the specific referral, it is linked to this BPA. There are two things that I think are important to note in this referral order. So I'll take you through. The first is that it's a stat order as our default. And then the second is that for depending on which of these three sites, you have to choose whether it is female or male. But the two important things that I feel are central to this order is the indication and then the anticipated treatment, because this allows the fertility specialist team to undergo risk stratification and have some idea of the type of services that can be offered to the patient. So once patients are referred, then that referral needs to be authorized by the primary oncology team. And so once authorization happens, then that referral order comes over to the fertility specialist, whether it's male or female, depending on the patient's sex. And so telehealth oncofertility is offered. So patients register as a new UCSD patient. They download the MyChart app for UCSD, and they undergo this telehealth visit. And then after the telehealth visit, they either complete because the consult was enough to meet their oncofertility needs, or they undergo fertility services. Component 3 is financial navigation. And I think we understand it, but probably don't talk about it enough in this setting, which is that to target financial hardship, I think that there is both material hardship, which is health insurance benefit access issues, problems with accessing philanthropic fertility preservation sources or health insurance appeals, and then also the need for psychosocial support around financial hardship. And so this was the goal of working with the Cancer Resource Center of the Desert. So with this multi-component intervention that was built following really doing environmental scans across 13 centers across Southern California, we ended up with these three aims for our project. So aim 1 of this project was to evaluate the effectiveness of the intervention on engagement in goal concordant oncofertility care among newly diagnosed cancer survivors. Aim 2 was to evaluate the impact of the intervention on patient-reported outcomes. And then aim 3 in a hybrid type 1 trial, which means that we in aim 1 wanted to understand effectiveness. We also wanted to understand how the program was implemented across sites. So this was a mixed method study approach. So this is what I mean by a step-wedge cluster randomized trial. Because the intervention is an EHR based at the start for the nudge, you can't randomize individual patients because then there's going to be contamination between patients of the same oncology team, right? So one breast cancer oncologist who sees 15 patients, if you randomize the patients, then that oncologist will actually learn over time to find the referral, and then for the patients, even if they were not randomized to the intervention. And so that's why our unit of randomization is actually the clinic. And so across these three sites, there are 20 different oncology clinics, each of whom have their individual teams. And so what a step-wedge trial means is that over time period, at the beginning, all clinics start on the sort of usual care. So white is usual care, and blue is when the intervention is activated. So the rationale for doing a step-wedge trial is that for some interventions, clinics may not participate if they feel that they will be randomized only to the control condition. So this has been really helpful for recruiting all three sites into the trial. And then every 8 months, in that time period of 8 months, is selected based on sample size calculations. Then a group of clinics that are randomly selected are then activated. Once activated, the clinics continue to have the intervention throughout the remaining duration of the trial. And so ultimately, we are asking if through electronic health review and audit reports to understand what type of oncofertility patient care each patient received, we want to understand whether the proportions that underwent goal concordant care in the control condition, so everywhere here in the white, is different from the proportions of patients who are seen during the blue time so that is the primary comparison. In aim 2, we will recruit 25% of the population who are randomly selected to answer patient-reported outcomes. And then in aim 3, this is a mixed methods evaluation of implementation. I hope that was clear, and super happy to field questions after. And so this is my complicated outcomes slide. And so let me take you through. Some of this may look a little familiar from a few slides ago. So here's a new patient, and a new patient should undergo oncofertility needs screen. And at the point of being screened, you either have a need, in which case you should be referred to fertility. Those people who are referred to fertility should be able to undergo an oncofertility consult. At that point, you may or may not have a fertility preservation service need. If you do, then we hope that you're able to undertake fertility preservation services. And then hopefully this is a yes, no here. So an example of goal concordant care is going to be, a patient who has these needs and undergo ultimately fertility preservation services. So this is concordant. But if for that patient who never underwent an oncofertility needs screen, that patient has discordant care, or they underwent a need screen and they have a need, but they were never referred or never underwent a consult or weren't able to undergo services, this is discordant care. So this is the primary outcome that we will assess through the electronic health record system. Aim 2 has patient-reported outcomes, and our primary outcome is the decisional conflict scale to measure decisional conflict on oncofertility care, on fertility preservation services decision. And so we wanted to measure engagement in care, decisional conflict, patient satisfaction, reproductive risk knowledge, shared decision-making, reproductive health and concerns, financial well-being using the enriched tool and intervention cost from the system standpoint, demographics, and then some health literacy. I wanted to shift a little bit to talk about aim 3. So implementation science is really the idea that interventions and evidence-based practices are poorly or not implemented. And if they're poorly implemented or not implemented, they really don't improve overall health as we should. On the right, I think you've seen this before, that from the time of an original research until implementation, on average, it takes about 17 years to transform a minority of our original research into the benefit of patient care. So implementation science is a study of methods that facilitate uptake of EVPs and research into regular use. For our aim 3, this means that in a mixed methods approach with focus groups with patients, semi-structured interviews with patients, parents, and providers, and observed financial navigation and oncofertility consultations, we would be able to obtain qualitative, quantitative data and actually checklists of how fidelity related to the types of things that we hope to happen during financial navigation and oncofertility consultations. That we would be able to collect these data, analyze them using a couple of frameworks. One is called the EPIS framework, which is a framework for exploration, preparation, implementation, and sustainment as a way of looking at implementation. And then our outcomes are based on something called the implementation outcomes framework. And the outcomes are fidelity, adaptation, acceptability, feasibility, appropriateness, and intervention costs. So for this trial, based on 18 clusters, 4 at Radies, 7 at UCSD, and 6 at City of Hope, we knew that at baseline, we saw about a 30% discussion of oncofertility risks. And we also needed the number of new patients on average and range per cluster per time period. We also needed to know the intra-class correlation, which is how often patients in the same cluster had similar outcomes as each other, others in the same cluster. And so using 90% power and an ICC of 0.3, we are able to detect a 30 to 45%, an increase from 30 to 45% of patients who will receive goal concordant care if the minimum number of individuals per cluster is 11 with 12. So if we wanted to have a baseline of 40% that have oncofertility concordant care, then to increase to 55%, then this require a minimum number of 12 per cluster. And this is just demonstrating the sample size in the power calculation curves. So this is where we are. We've completed time 1 and completed time 2, and we are smack dab in the middle of time 3. And the total anticipated size is around 2,000 for this trial. Let's see. We have several lessons that we wanted to share in the about 20 months that we've been conducting this trial. The first lesson is one IRB is super clunky. And it would be nice to have the expertise of regulatory folks to make one IRB a lot more accessible and quicker. The second is that there's intervention adaptations that are needed to improve the fit, and I'll show you a couple of examples. One of the nice sort of offshoots of the project is that there's been a lot of funding interest in medical financial hardship and disparities. And so this project dovetails really nicely with an R21 that we're finishing on policy implementation of fertility preservation benefits. And organizations like RWJ have been really interested in this area and funding this area. The other lesson that's so painful is that across the board, 17% cut in NCI R01s makes it really challenging. And then finally, working with pediatric oncologists is just awesome, but you guys know that. So I want to talk a little bit about intervention adaptations. There's this notion that you should have thoughtful, deliberate modifications to your interventions to improve the fit. So I think to me, it speaks more to the idea of interventions being effective and not necessarily just efficacious. So not in the sort of purest, best world setting, but more in a real world setting. If an intervention doesn't really quite fit, how can you make it better so that we don't finish a trial 5 years from now and realize that it didn't work because it didn't fit as we expanded to multiple sites and multiple clinics. This is different from a term called drift, where you're supposed to do something, but just over time, it slacks and then you just drift away from what you were intending to do. And you want to systematically capture these adaptations. The next slide is a little busy, but I'll walk you through it. So this is the Sturman framework for how do you capture interventions. And so going from the left, there are questions in this framework on like, when did the intervention take place? Were they planned? What was modified? And once something is modified, at what level was it modified? What are the contextual modifications here that were made to modify the intervention? And then what is the nature of the type of modifications that we undertook, and why? The reasons why it's important to actively adapt, but also document these adaptations is because if the intervention is successful and we want to be able to scale it, I think we want to be able to say across different sites, different oncology settings, or different fertility clinic settings, what were the tweaks that had to happen in order for these 3 components of the intervention to be effective. That way, it in some way hopefully reduces future clinics of every clinic trying to figure out some process that works for them, because we've had an opportunity to document that variation ahead of time. So to date, we have had 21 recorded adaptations. The most of the adaptations is in component 1, which is the EHR nudge, primarily in acknowledgement reasons. So these are really tweaks. So oncology providers, as they are onboarded to the activated intervention, they're letting us know that not all of the reasons why they feel that an oncofertility care referral or services is needed, that they're not all there. And so really hearing from your partners what it is they need to make their practice more efficient led to adaptations to, for example, the acknowledgement reasons. The second is that the way we built the BPA is that it is based on a new patient visit type in Epic, which is our EHR. And it's also based on an oncology cancer diagnosis. And because we're interested in new diagnoses, then we obviated the set of recurrent diagnoses codes. But for example, we didn't realize until we hit the GYN oncology team that actually they don't bill using the GYN oncology codes until after a diagnosis is made. And because oftentimes surgery that occurs ahead of time can be toxic to fertility, for example, removing both ovaries. And so this BPA would not have popped up because the code for the surgery was a pelvic mass rather than ovarian cancer, for example. And therefore, as we introduced this intervention to different oncology teams, I think they were able to feedback on how do you make the BPA work better for them. Almost all of these adaptations required clinicians and an Epic analyst input. Almost all of them are planned. And as I said, the goal is to improve fit and improve reach. It's a lot of tweaking and not truly large changes to the intervention. And so I showed you where we were at the beginning, and this is where we currently are with the nudge having a new look. Different dismissal reasons than at the start, or really an expansion of the dismissal reasons at the start. And then I think we have to rethink component 3, which is the financial navigation piece. So I wanted to share, let me make sure I'm good on time. Great. Some lessons we have from our fertility preservation benefit mandate policy implementation. So when we think about policies in oncofertility care regarding health insurance coverage, there are big policies and little policies, or big P's and little P's. So big P policies, we think, are really national state level policies. For example, clinical society guidelines, health insurance benefit mandates. Little P policies happen at local and organizational levels. So those are decisions made by health insurers, made by health systems, oncology practices, and fertility practices. And we've all been so excited by our collective work for insurance mandates for oncofertility care. As you know, there's still no federal mandate, but that for state health insurance plans, there are now 17 states between 2017 and 2023. In our home state of California, this law is called SB 600, which was passed in 2019. This is a busy slide too, but let me take you through it. So we wanted to understand how much difference is there among these different state mandates. And these were the first 11 states that passed state level fertility preservation health insurance mandates. And in the red, what you'll see is that markets that are covered are actually really different. So for example, in California, individual, small group, large group commercial plans are covered, but Medicaid is not. In Connecticut, individual plans are not covered, but small group and large groups are, and then Medicaid is not. And so currently, both Illinois and Utah have public plans coverage, but in Utah, actually commercial plans are not covered. So at the start, you have different populations covered in different states. And actually, that is based on the state in which your health the purchaser of your health insurance is based. Let me make sure that I can kind of clarify. So in the US, we divvy up health insurance as being public or private, right? So public insurance is going to be Medicare, Medi-Cal, TRICARE, health, military insurance. These are publicly insured individuals. Then among privately insured individuals, you have insured patients who are in fully funded plans versus patients who are in self-funded plans. And so fully funded plans means that they're regulated by the state level. And then self-funded plans means that actually organizations like the University of California that are so big, it turns out that Blue Cross Blue Shield is really administering our insurance benefits, but ultimately the payer of those benefits is UC San Diego. So as a self-funded entity, self-funded plans are not subject to state regulations, they're subject to federal regulations. And so that is why when a patient sees you and they're like, oh, I have a PPO and it's Aetna, you can't tell whether they have eligibility for these benefits, even if you're in a state like California with a benefit, because you don't really know if that plan is fully insured or if it's self-insured. So this is just showing you California. The second thing in thinking about these fertility preservation benefit mandates is that the coverage specifics are really vary a lot, and they're often not specific. And so here I'm showing you across the states, for example, California here, and across most of these laws refer to our clinical guidelines, which is great because that becomes a lever point for us to use medical evidence to inform policy and downstream patient care. But in our state, our law doesn't have any specificity about whether oocyte retrievals, oocyte cryopreservation, embryo cryopreservation, sperm cryopreservation, storage, cycle limitations, none of this is specified. As opposed to, for example, in New York, in this column, where you see that there's a lot of more specificity in the language. And we hypothesize that with less specificity, you're going to have some dilution of your downstream implementation. So after we looked at these policies, we wanted to understand, well, what happens after the law gets passed? And we wanted to use an implementation science approach to see what happens at multiple levels downstream. So in case you didn't know, once a state law passes, then there is a regulatory agency in each state, and that regulator has to interpret the law so that insurers can understand what it is they have to implement. From the regulators, then the insurers go on as the next level of implementation, where multiple processes have to happen within the insurers. Clinics actually are so excited that there's now potential more health insurance benefits for our patients, have to implement processes to be able to access those health insurance benefits before it gets to patients. So in this work, I think my take-home points here are there are big P policies that affect implementation at the level of the regulator, insurer, and clinic. And then there are lots of little p policies that are derived from the initial big P policy. And I'll give an example. So at the level of the insurer, they can see what the California law says. They can see what the health insurance regulator says. And so they have to have policies that comply with these, big P policies. And this includes designing fertility preservation benefits that are consistent with the law or that comply with the law. That also means that they have to establish clinic contracts and letters of agreement when clinic contracts don't exist. They have to have processes for verifying patients' benefits, pre-authorization, and claims processes, and build that for both patients and clinics to be able to access when they're asking the health insurer, do I have coverage? How do I access it? And they also have to bundle this and train the people inside the health insurer, member services, provider services, and the claims that there is now this new benefit. They have to communicate that there's a benefit to members and communicate that there's these benefits to providers. And really, at the level of the clinic, many clinics actually do not contract with health insurers, but now may, or go through letters of agreement until a contract with the insurer is in place. They have to have enough staff to help with this process, and then potentially modifications of the patient payment policies where it's possible that clinics previously thought there is no coverage and therefore ask for cash costs up front, but that multiple clinics have changed their practice because they think that if a patient looks like they would be eligible for health insurance benefits, even if you do not see that benefit inside their health insurance plan handbook, that this is appealable through the state insurance regulators or through the insurer. So the payment approach also has changed. But it's inconsistent among these different levels. So that's why ideally we're starting off here with this nice, navy box of what it is we intended to do. But as the laws get implemented in each of these levels, it's getting diluted and changing the shape before it ever gets to our patients. So never followed a law from the time that it passes all the way into the patient's hands. And I think that what we want to do with this information is to figure out how to design and develop interventions for clinics and patients. So following document reviews, interviews with insurers, and a number of oncology and fertility clinics, and we are at the start of discussing with or obtaining data from patients of different clinics. These types of qualitative data go through thematic analysis to identify barriers and facilitators. There were a lot of barriers and facilitators. Then partners will rank and rate these determinants, and we then map the highest rated determinants, so the highest rated barriers and facilitators, to potential strategies that we can design and implement. And so below is to show you that our goal is to design patient and clinic-based interventions. So this is what our patients go through. And I think that they need to teach us more of this in medical school. So a patient needs a fertility preservation consult or a treatment. So the first decision point is, do they have health insurance? No, they pay cash. Yes, then they go through benefit verification with the health insurance company to say, do I have a health insurance benefit for fertility preservation or not? If no, then you pay cash, or you could potentially appeal to the insurer because you think that a benefit should be there. But if yes, then actually the next tricky thing is, are there in-network providers and facilities? And if no, do you have out-of-network benefits? And then out-of-network benefit verification leads to, either you see an out-of-network fertility preservation specialist, or oftentimes this process has taken time and patients basically pay cash and try to get some reimbursement back later from the health insurers. If you're down here and you have an in-network provider facility, awesome. Then prior authorization is needed. And then if you get prior authorization, then hopefully you get services. And then if not, then you appeal to the insurer or you pay cash. This process is supposed to happen in 2 to 3 days so that our patients can actually undergo the care that they need. And we can all sort of speak to various challenges that we've had in this process. So my question for the group as I wrap up is really the fertility preservation financial navigation intervention in study design is that we think that the key barriers are at the steps of benefit verification and figuring out whether patients have in-network places where they can go. And then the process of appealing seems to be a hodgepodge of various strategies. Potential interventions for patients are, what we've done a lot in Oncofertility, which is to have individual navigators trained up to do this. But in many cases, different patients need different amounts of help. So are there other tools that can be more basic and more disseminable, at least for some patients to be able to access their health insurance benefits without having a navigator? The second, of course, is that navigators can be remote, so that not every oncology center and not every fertility center can or needs to hire individual navigators. At least through Medicaid, we've had some early experiences that patient navigation may be funded. And so this has hopefully long-term sustainability if health insurance is able to offset some of the costs of navigation beyond the confines of a clinical trial that's funded. For clinics, this is really best practices. I think that our understanding of clinics here in California is that the ones with buy-in, the ones that want to do this extra work for patients, are all trying to figure out the process for themselves. And largely they're arriving at the same conclusions, but sometimes through repeated and similar journeys in parallel, when this can be learned information and disseminated more easily. If we have financial navigation interventions, the question for the group is, what is the setting to test whether this intervention works? Is it intervening on the oncology practices? Because if you intervene on oncology practices, maybe that will get buy-in from the oncology team that there can be coverage, and therefore not lose the patients who, after they leave the oncologist's office, never come to the fertility specialist simply because if one of the reasons is concerns about cost? Or is it really where the larger costs are, which is at the fertility clinics? Do we do this at the new patient engagement when patients call? Do we do this after their appointment so that it is trying to facilitate being able to have coverage for the services that they hope to have? Do we do it after fertility preservation treatment when claims and appeals are happening? How do we evaluate this? Do we evaluate this as a cluster randomized trial again? Do we maybe evaluate this as a SMART or an adaptive trial? And in that type of trial, you start with a lower cost intervention. So some low hanging fruit where patients can help themselves to figure out some of these steps of financial navigation or navigating health insurance. And if they cannot, then that's when you escalate to using a health insurance navigator. So those are some of the questions that we are trying to think through, and would love feedback from the community. So my last two slides are the many, many people who work on this project with us. And of course, being grateful that along the way, we've been able to garner support locally from our institution through something called CureBound and UC San Diego's CTRI, and ultimately to the NCI R01. And then on the implementation science project on policy implementation, lots of great IS folks and then clinical collaborators across Illinois and across New York, and funding, again, institutionally and from Robert Wood Johnson, Doris Howell, and the NCI. So I'm going to stop there, and thank you very much. Really happy to get feedback and answer anything that wasn't clear.
Thank you so much for a wonderful presentation. That was so informative. I'm so impressed with everything that you've done. There are some questions in the chat, so we can look at those questions. One of them, great presentation, which I definitely agree. Do we know if most fertility centers are able to apply the newer legislation requiring coverage for cancer patients?
So we have a small sample, 16 clinics, and in those 16 clinics, it's variable. You have places like, the Maserati of Oncofertility care, like Northwestern, where everything that they're doing is trying to apply health insurance benefits to the care of our patients, to clinics who continue to take cash only and give patients receipts after to try to get reimbursed from their health insurance. So it's all over the place. It feels like bigger centers that have a champion are going to be the centers that will uptake fighting the insurance, the good fight to apply these health insurance benefits. The second question is, so did that answer your question, Gwen?
Yeah, I think you might have talked about it with Joyce, but I think with Joyce Reineke of the Alliance of Fertility Preservation, I think that's what we're hearing in other states too, is that either the fertility center is saying, I don't know anything about that, I'll give you a receipt, you can try and get reimbursed. But all of that is holding, the checking in to let me see is holding up a process that people often have very limited amount of time for anyway, and probably can't, in most cases, get the cash together to do it.
It's actually, so I think, and I didn't expect, and that was something great to learn. So for example, at UC San Francisco, they have a champion, lots of champions for utilizing health insurance and advocating for health insurance coverage. So then they went down the road of trying to figure out whether a patient should have coverage, not necessarily whether. So the first triage point is, does your plan handbook or does member services tell you have this benefit? If no, it doesn't mean that you don't have the benefit. It could just be that was bad implementation by the health insurer. So if they think that you have a benefit, they will ask you for I think 10% upfront deposit, and then go through the cycle so you don't have to worry about coming up with the rest of the cash. Post, they will fight the good fight with the insurers for you until they figure out how much your responsibility is. But they can do that because big enough of a center, enough of a team, enough of an investment, but not every place is the same, right? And so are there pieces of this that can be taken out of individual smaller mom and pop fertility centers that can be maybe done more remotely with like a remote navigator or remote teaching of patients?
Yeah, that's helpful. That's good to know too. I hope they disseminate what they're doing.
Yeah, I think yeah, that's our goal. And then the second is, why are patients with poor prognosis excluded from counseling? Yeah, so this is really so they're not excluded from counseling, but I think that this is a push-pull of trying to decide our outcome. Is it goal concordant or not? And so through the patient-reported outcomes, we'll assess a proportion of patients to see, regardless of whether they went through fertility preservation or not, to see what their goals were. But the oncology team feels strongly that there are some patients for whom this is not appropriate, and that the reason why they didn't move forward with fertility preservation is because of poor prognosis. So this was one of the acknowledgement reasons that was brought up by the community.
Yeah, I'll follow up with you about that, because I just got a supplement to echo to look at posthumous policies and whether autonomy, is respected in the cases of adults, and for minors, what people are doing when parents want gametes from a minor. But yeah, I just have my own personal feelings about that it shouldn't be a reason not to offer someone both counseling and referral if they're interested, but certainly understandable why a patient would say no. I might have misheard, but I thought the checkbox was like, if they had a poor prognosis, that was a reason not to have a discussion.
No, I think that it's, why did you not refer to fertility, not why did you not discuss?
Okay, thanks.
Sure.
I have a question. So I'm somebody who recently moved from a state that had a state mandate for fertility preservation that was wonderful to a state without a mandate. And one of the things I've noticed that patients that have publicly funded insurance, especially in the state I am currently, that there's a barrier just having government sponsored insurance to have a consultation. I wanted to see what your experience was with that, or if you've identified any other barriers to access to care that might be unique.
So actually, I feel, at least in our experience, for our publicly insured individuals, so we sit in academic centers that take public insurance, right? And so, and we are, for example, a Medi-Cal contracted provider, for myself. And therefore, I don't think that patients who have had Medi-Cal have had difficulty getting the consultations. And actually, for a few of our tissue freezing cases, the laparoscopy has been authorized and covered by Medi-Cal, but not the pieces of egg and embryo freezing. So we haven't had as many issues here with Medi-Cal coverage of consults. But it's under the auspices of an oncology diagnosis. So actually, this is one of the things that the Alliance for Fertility Preservation group brings up a lot. Like, what is the algorithm of diagnoses that you have to put in order to have that visit or that service covered? How do we know that, right? So the big black box of the health insurance to me is, so we divide visit codes into diagnosis codes. That is a rationale for why you had 20-minute consultation, 45-minute consultation, or you underwent an ultrasound, right? So those are the two pieces. And if you use the fertility preservation diagnosis code, that's a hierarchical code under infertility services. And so if the big black box inside the health insurance for which codes are allowable for oncofertility consults falls under infertility, and then the parent code for infertility is not covered, then you're not going to have that piece. But the problem is that these procedure codes, for example, for potentially egg freezing or egg retrieval, those codes, the procedure codes, are not necessarily linked with breast cancer or leukemia or whatnot. And so if you use the oncology code, you may not actually ever get that covered because they're not synced, right? So I think kind of in a roundabout way, trying to sort of highlight where we need a little bit more understanding, so there's easier, so that when we code, it's better covered for our patients.
That's great. Thank you.
How do we disseminate this information? I mean, you're the head of the coding committee. Nobody ever taught us this in medical school. It was really differential. Some oncology and some fertility providers feel like there's a separation of church and state, that we talk about what is medically necessary, what is medically indicated, but we don't talk about what this is going to cost. And others of us feel really differently because, you know, you can't do the services if you can't afford them. But they never taught us this. So what do you think? How do we fix that?
I think it's actually kind of challenging because there's like the coding according to the rules, how you're supposed to code, but then there's like how I've been taught to code to have insurance cover services for patients. And so like whether it's the cancer diagnosis is the primary diagnosis or the fertility preservation counseling is the primary diagnosis. And sometimes it varies according to the payer. And so I think all we can really do is just kind of follow the guidelines. And we do have some guidelines and I'm updating them now because I do think that people need this resource, because if people like you and I who do a lot of fertility preservation counseling are having trouble like deciding what codes to use, and I actually personally sometimes find it very confusing, then we can only imagine people who are just starting to build fertility preservation practices. And so I think it needs to be part of the toolkit, you know, along with like having a fertility preservation navigator. It's like the billing and coding aspect.
How much of this do you all think that patients can manage on their own? Because there's never going to be enough financial navigators for every patient who needs it. The average amount of time that navigators were reporting per case is 8 hours. 8 hours.
Yeah,
So
I mean,
there's some, go ahead.
I'm just wondering, I'm processing what you're saying, but I'm wondering, you know, they have people who do this for other things. You know, we know this was what helped change legislation, that mastectomy or that reconstruction was a covered service because people, you know, wrote templated rejection letters and people did that. I'm wondering if we need like a whole new phenotype of a person, or can we use people who have already doing this in other contents and constructs, because it certainly benefits the patient, but it also benefits the center to put resources into recouping as much as they can.
Yeah. It feels, at least from these interviews, from I guess they're called like the benefit verification people, prior authorization people, and claims people. It's like 3 different types of jobs inside this financial piece. And so it feels like it's harder than, for example, mastectomy, because the benefit designs are so variable, and then the way to access that benefit is so variable by health insurer. And that piece of it is where it seemed like the mastectomy coverage was a lot more penetrant. You can see that from this health insurer, like the types of plans that are covered, it's variable, and you can't even tell who is in state and who's not, you know, in state, and who's fully funded versus self-funded. If you call the health insurance company, even if you know someone is self-funded, you're not getting the right answer from the member services. It's crazy. There's some interventions in the AYA cancer space about financial understanding health insurance. I think that's the first step, right? So these interventions of like some videos, some sessions, so that patients know what, you know, a claim is or what pre-authorization is. I thought about really just, depending on the outcomes of those couple of trials, applying those tools to our patients. But it feels like it's not enough just to know those terms. You actually have to figure out how you go navigate and use this fertility preservation benefit.
I definitely think it's hard. I remember in 2019 when I was in Maryland, when they first had the state mandate, I would say it took a good year before insurance companies started to really recognize that this was coverage, and I would have to submit a treatment plan and then sometimes even appeal. But then when they realized that there was a state mandate, their coverage became more pervasive. But it took a while. There was definitely a learning process.
But I would
We-
say in New York, we've had it for 3 years, maybe longer, and it's still a mess. And I think it would be great to help patients, but I just don't think the average oncology patient has the wherewithal at that time to take this on. I think that's why so many patients just say, once they find out about costs and availability of, yes, you can get the drugs through some programs, but some of these actual procedures, are harder. So it's just easier to say, just forget it. I'm just going to focus on the treatment that I need.
Yeah, but I think the difference between California, New York, and I would venture to say Maryland, simply because Illinois was the third state that we looked at, is that Maryland has an existing IVF benefit, right? Whereas New York started the general IVF benefit and the fertility preservation benefit at the same time. And that's why the onboarding, the implementation is harder. And in California, we have this fertility preservation mandate, but no IVF mandate.
Yeah. I think part of it also could, would benefit is like retraining the schedulers who are answering the phone. And the first thing they often do is talk about how much things cost, which can be a big deterrent. And sometimes patients really, they will eventually care about cost, but they want a physician to tell them what options might be available to them based on their cancer and their prognosis and the treatment that they're going to have, versus leading with costs. And then patients are like, forget it. Everybody just cares about money.
Yeah, I think that's right. And that's a really important point.
Which may be something that fertility centers can do who are participating in this, is be transparent about pricing, on a website or, a searchable way.
So it turns out that fertility centers don't want to be transparent about this. And also turns out that there is a sex difference in terms of having in-network providers for female fertility as opposed to male fertility. So actually very few sperm banks are going to be contracted with insurance companies because the reimbursement is too low.
Yeah. Well, that was very interesting. I think it would be great if, as you're available, to keep updated on as that moves forward, and looking at other states and some of those differences that you notice, like had an existing IVF plan versus coupling it in with oncology.
Yeah. Any other questions from folks? Sorry, I feel like we've been having our own conversation.
Are there any other questions from the chat or anybody? It was such a robust presentation. It was just fascinating. And I can't wait to, as the study progresses and we gain more information, it was wonderful.
Oh, thanks for having me, you guys.
Okay, if there's no other questions, we will conclude our webinar, and it will be available on our YouTube channel for the Oncofertility Consortium for those who would like to rewatch it or watch it in the future. Thank you.
Thanks.